And we are moving into a final closing session to take time to synthesize and really think about what these 2 days have looked like and hear from a lot of different stakeholders in that process. So without further ado, let me introduce you to our moderators for this. Robert Saunders is Research Director of Payment and Delivery Reform for Duke Margolis Health Policy Center. And Rebecca Kirch is the Executive Vice President of Healthcare Quality and Value at the National Patient Advocate Foundation. Apologies, I'm seeing National Patient missing off this. But again, please remember, before I let this go, that you, in your symposium materials, have access to all of our fabulous presenters' bios and slides, all of the panelists, your post-survey information that we want to hear from you, and everything else you'll be looking for. So let me pass this on to the moderators. Thank you.
Great, thanks. And I'm Rob Saunders from the Margolis Center at Duke University, and I'm excited to be able to moderate this session along with Rebecca Kirch. So we've had a great conversation over the last 2 days, and the goal of this panel is to synthesize, and I think we've got around 30, 35 minutes, everything that we've heard, and come out with some key pearls of wisdom that will both be inspirational for what we can do, but also give some sense of next steps and where we can go next. So my job at first is in 4 minutes to give my gut of what's the synthesis of those top take-home messages, and then turn over to the fantastic panel that we have. So I heard probably about 5 different things here. One theme that I've really taken away from the last 2 days and have been really excited about is just the number of examples of really dedicated, skilled people providing comprehensive, integrated pain management in a variety of organizations, populations, geographic locations. So the problem that we have is not that we don't have good evidence on what works. In fact, we have some great evidence on really fantastic programs that have been able to change people's lives. The big challenge is really scalability and implementation. So how do we take these innovative models and put them into more places so that folks don't have to drive 2 hours to Kansas City to see someone, or 3 hours across the mountains in West Virginia to see that fantastic center, but they can get things closer to their home and when they need it. We also heard from skilled professionals trained in a variety of disciplines, and the last panel, the last presentation that Bo gave, really highlighted the secret sauce is how do you customize and bring together those varied services according to a person's needs, goals, and preferences to be able to meet their pain challenges. And of course, this brings a challenge in that in other areas of healthcare especially, you tend to have some guidelines or protocols. And here we're talking about how do you provide flexibility in those services with a focus on overall outcomes, or as Christine Kurtz noted, preferably patient-reported outcomes that we can look at. Another big challenge that I heard over the last 2 days was really demonstrating the business case and return on investment. The last panel went into depth on the information payers need, whether public or private, for coverage determinations, for benefit design, for payment. Yesterday afternoon's closing panel really emphasized some of the evidence employers are looking for as they're designing their plans and engaging employees. And we heard yesterday and today from delivery organizations about the type of evidence their financial and executive leadership needed to make investments in infrastructure. So we've got some good examples of where these organizations have been able to demonstrate the business case. And again, now the challenge is how do you spread that more broadly so others can do so as well. And of course, there are a variety of other policy changes that affect that scale and implementation. Just to sort of rattle off a few, licensure, some of the changes to alternative payment models and payment reforms, education requirements, pre-auth or prior authorization, data sharing, carve-outs that separate behavioral health and physical health. All of these make this difficult. And then finally, everything's been colored by COVID-19, which is the reason we're meeting virtually in the first place. COVID has affected access for people with pain, but it's also led to major shifts in service delivery through telehealth and virtual options that frankly we wouldn't have seen for years, if not decades, So there has been that shift, and now the question will be, how do we take the changes that have been positive, like that shift to telehealth and virtual options, and make sure they continue even after the pandemic has passed. So now let's turn to the panelists. We've got a great group here. We don't have time to do introductions, but we asked this distinguished group to share in 90 seconds the pearl they took away from the symposium, an idea they heard that they appreciated, a new idea that was presented, or next steps that they see can really take the field forward after this symposium is over. So let me turn things over to Rebecca Kirch, who's going to moderate the discussion and then share her synthesis of the day.
Thank you, Robert. Welcome, everyone. We do have a large, stellar panel, a dozen. So without further ado, we'll just ask each of you, please, to, if you have the capacity to put on your camera so we can see you while you speak, that's wonderful. But explain a little of the context that you're offering your inspirational take-home pearl from to help set the tone for us wrapping up this wonderful two-day symposium. And we're going to start with Bo, who we just heard from. So Bo, if you could kick us off. Thank you.
Okay, great. Well, thanks very much, Rebecca. So my pearl is, as the infrastructure for payment and provision of multiple approaches to pain management within the medical systems developed, there will also be a need to focus on preparing clinicians and administrators, as I was discussing. Clinician training programs also need to include interprofessional education, as I mentioned. And for the complementary and integrative healthcare programs, there also needs to be content on working within healthcare systems and about all of the integrative approaches to pain management. The accreditation bodies will need to be brought on board to ensure that this actually happens. Administrators within the healthcare systems will need to develop credentialing systems for the complementary and integrative healthcare therapies and understand how these therapies can be best undertaken within those settings. The payers will need to understand the challenging process of translating the clinical practice guidelines that have been derived from the clinical research into real-world practice. And this is going to directly impact the coverage limits and specifications. And we need to address those to ensure that the effectiveness of these therapy is not negatively impacted.
Thank you so much, Bo. I think one of the themes we've heard across the 2 days is this trajectory of where integrative pain management has brought us to the place where it's really an emphasis on socialization, standardization, and we hope monetization at a scaled level. So I appreciate that, both the last presentation, but also you summarizing some of the work we need to do around preparing clinicians, administrators, and the steps for doing that. Let's turn to someone who represents people with pain, Maggie Buckley. Share with us some of your thoughts, Maggie.
Effective pain management is a team effort centered on a patient with consistent communication and coordination between all members of the team. The expertise of every team member, including the person with pain, is enhanced by collaboration. We need to figure out the best way or ways to cover and facilitate coordination. Nurse case manager, social worker, insurance representative, independent patient advocate, etc., whatever form that's going to take.
Thank you, Maggie. And you know what I think is so critical about your reminder message is that the people with pain are experts in their lived experience, and the importance of that as part of the integrative care team is vital. And that's a message I know I've heard from Penny Cowan for years as well. Penny, share with us some of your pearls. You need to unmute, I think, Penny, so we can hear you.
Can you hear me now?
Yes.
Okay. All right. So sorry. Thank you for including me in this panel. And what I've heard was very hopeful for me, because so many people with pain today are struggling, trying to get access to care and that, and they're not understanding the real that integrative care that they really need in order to begin their journey from patient to person. But I think the most important thing is that it has to be patient-centered, because without their participation, without their buy-in, without the support of all the clinicians, all of the therapists, if that person with pain doesn't take an active role, then nothing's going to work for them. I mean, they have to be. So what I've heard throughout the last 2 days is that we have people out there who actually get that, because for a long time that wasn't happening. I've been doing this for over 40 years. And so we missed a lot of that interactive between patient and person with pain, with the clinician. So we really need to include the person with pain. We need to empower them to take part so that they can improve quality of life, increase their function, reduce their sense of suffering. Pain has such an impact on everyone's life. So I applaud all of the speakers for what we heard today and the efforts that they're putting forward. The one thing I'd like to say, though, is that I think we need more research so that the payers actually see it. That tends to be what I keep hearing in all the meetings I'm going to, is that we need more research in order to get the payers to actually pay for the services that people really need. I know acupuncture is moving forward, but there's so many other pieces to that. So thank you.
Thank you, Penny. Research and those who help communicate the findings of that research to demonstrate the value. Couldn't agree more. Patricia Herman, you have an interesting perspective from the economic side. Will you share with us some of your thoughts from that perspective?
Sure. Over yesterday and earlier today, we have heard a number of really good presentations about comprehensive integrative pain management and how important and effective it is for people with pain. So I think we got that, and definitely you can always have more research on that. But however, every great idea needs to have a viable path to fruition, or it's just not going to happen on any kind of big scale. What we're going to need to make this type of pain management available to all who need it, it must become economically viable, and to providers, health systems, payers, purchasers, patients. And how are we going to do that? Now, the presentation in the last session by Adam from the Hartford laid out some of what those payment models look like. And yes, we do need new payment models. But let me just say something even simpler than that is like, how can we help that happen as individuals, as patient advocates, as people with pain, as providers, as researchers, is to reach out to the various groups and start to create those communication links as to what do you need? What do you need to make this change? What kinds of information, offer to help? That's one of the things that happened in the Vermont situation, which is looking so promising, is that Josh Plavin and Robert Davis got together, an acupuncturist, and they figured out, okay, how do we get this moving forward? So in doing that, it's engaging. It's also coming up with the evidence, making sure maybe helping review the evidence. And then also one of the things Josh pointed out in that situation is having patience, because to move this huge ship even a little bit, it's going to take some time. But I think that the momentum built here is going to be very effective in moving that forward. So I'm wishing us all well on that process.
It's interesting because another important theme that's important for us to reinforce as we leave this symposium is the healing touch is a huge value that may be hard to quantify in economic terms, but that's an essential aspect of this. And the role that the people who are benefiting from that healing touch can play in helping us quantify it by sharing their stories, I think will be a critical, influential aspect of how we make that case. Douglas Nelson, will you share with us from your perspective, important integrative therapy aspect that you bring?
Sure. I think the key points for me that surfaced kind of revolve around two areas. One is the personal cost of pain and the significant economic cost of musculoskeletal pain in particular, which matches much of the data collected through our own research and consumer surveys. Now, on the personal side, people in pain so often feel invalidated when seeking care. We heard that multiple times, and it's vital that patients feel a sense of agency, validation, and self-efficacy. For us, when a massage therapist replicates a client's symptoms through manual palpation, that's a really, really powerful form of validation. And when people feel heard and acknowledged, that fosters a greater sense of engagement and hopefully creating a desire for a deeper understanding of the mechanisms of pain and potentially then better compliance with suggested pathways. You know, we also saw that patient preferences drive service choices. Dr. Khan's data showed us the utilization rate of massage therapy is really high. Newsflash, people actually like massage. But, you know, in that, you know, massage therapy can be a powerful catalyst in an integrated system, in that way creating a portal that may lead to utilization of other services as well. And Julianne Spini's presentation yesterday, I thought was a great example of that, how massage therapy was integrated in with corrective exercise. You know, it's great to tell people to move, but if moving hurts, that's hard, right? So if therapeutic massage can make movement more comfortable, people are more likely to move more. And we all know that that is extremely beneficial. And of course, several presentations illustrated the significant economic impact of integrating manual therapy into pain management. Dr. Kligler and Dr. Elton's data was really compelling, and how those approaches can save significant dollars and serve the patient more effectively. So massage therapists are licensed in almost every state in the United States, but there are significant barriers to access produced by lack of coverage from providers. The American Massage Therapy Association and the Massage Therapy Foundation have been at the forefront of addressing those barriers through research, policy, and collaboration. And we recognize that none of us can address these many layers of barriers alone, but we're eager to continue to be part of the collective conversation to further the progress of effective pain management. And thank you.
Thank you so much, Douglas. And Stephen, share your perspective as well, please.
Oh, thanks. I'm Stephen Stanis. I'm a pain medicine specialist and physiatrist in Seattle. And just my background is I run a functional restoration program within a kind of typical pain clinic where we do procedures, neuromodulation. We have an addiction specialist. So starting a pain rehab program 3 years ago, this day of meetings has actually kind of spurred a lot of thoughts in my mind. I think the two areas, maybe not just pearls, but next steps are payer coverage and benefits changes that really needed to be done, not in the short term now versus doing this later on. There were some great lectures on population health and bundled payments, and Adam had some great comments about patient-centered payment systems, which are great, but I think we really need to work in the fee-for-service model that we live in. For me to push a pain rehab program to our hospital in the midst of a COVID epidemic where they're having financial issues, we have to kind of keep that in mind. For payers and plans, how do we increase access? I know, and many on the phone probably or on the webinar can understand this, in our own pain rehab program, our patients that are even recommended for a rehab program, and our program is about 15 hours a week for 4 weeks, and it includes physical therapy and occupational therapy and psychology, pain education. They go through this severe kind of confusing journey just to get things approved. There's really a lack of group coverage. Patients are paying multiple co-pays, some patients up to $200 and $300 a day for a pain rehab program. So I think there's important things that can be done in the short term from the payer side to help kind of decrease some of those barriers so we can really push these programs within a larger health system. The second point would be just within COVID. Our hospital just announced $300 million proposed loss of revenue by the end of the year. University of Washington, $500 million by the end of the year. So in the midst of the COVID epidemic, outpatient clinics were already struggling. Many outpatient programs, whether it's PT, primary care, pain clinics, they've always been considered money losers within a healthcare system. But they needed those to kind of fulfill the mission of the hospital and to keep the main hospital going. With those huge financial losses now, some of the pain programs and a lot of these services we're talking about that really work are going to be on the chopping block. And so how do we really defend those and use this opportunity to show the benefit of it? And so, the one pearl I would say is I think we all have to kind of use our experts. We've actually had our own PTs and OTs and relaxation therapists doing videos now when we developed the whole website for our hospital, what we call Care for Caregivers, where patients get staff members can actually watch 15-minute videos on relaxation and chair yoga while they're at work. So we really need this time, I think, to push and get out there the education on what we're doing to provide comprehensive care, and then understand the hospitals are going through a financial constraints, and we're going to really need to kind of think in the short term, how do we defend what we do so we can increase access. So this has been great, and again, I'm just hopeful that we can use this opportunity for telehealth and everything else to show our benefit.
Thank you so much, Stephen. I think the rehabilitation aspects to complement what you just described are essential too. Alice Bell, can you talk to us about that side of the house?
Sure, Rebecca, thank you so much. And it's an honor to be part of this panel. Just a couple of thoughts that I'd like to share. One is that individuals with chronic pain, as we've learned over these 2 days, will ideally receive care from a team in a shared environment. But that is neither a requirement for effective performance nor an excuse for non-performance. And I would just say that as care providers, it's our job to facilitate and support access to team-based care and resources, and to work collaboratively with all participants, regardless of the infrastructure in which we operate. If anything, COVID-19 has taught us that meaningful relationships are not dependent on shared physical space. And although that may be an ideal objective, and much of what we do collectively and what we do individually as providers may be better if we are in the same physical space, we can effectively do a lot without sharing that space if we're mindful of operating collaboratively and collectively. I'd also like to share that I think we often attempt to provide person-centered care in a system that's anything but person-centered. Even the consideration of the term comprehensive must be considered in the context of person-centered care. What's comprehensive for one patient may not be for another. And we need to resist the urge to define comprehensive by the length of list of services, and rather by the determination that we're doing everything that's necessary to meet the needs of the individual versus everything that's available or possible. Control starts with knowledge. One of our primary roles is to arm people with that knowledge and work together to design a self-management strategy that's aligned with a person's goals and values, while utilizing, and I think we heard this, meaningful measures that inform both the patient and the payer of the impact of their investment. So thank you.
Thank you, Alice. And what a helpful and powerful reminder. The words we use and think about comprehensive can have many meanings, and it's probably best that we ask the people with pain and their caregivers what it is that they need, rather than us assume what comprehensive may mean for them, as well as how we think about the quality measures, as you've highlighted. Gary Klum, I see you there. Can you offer up some pearls for us as well?
Thank you very much. I'd like to take a step back from the immediacy of the discussion and the facts and the figures and everything we've had, and think about how different this conversation would be had the opioid crisis not come to a head and come on the scene as it did a few years ago. And that the very conversations that we're having, like the discussion we had today about how telehealth has been advanced by COVID, the circumstances of the opioid crisis has allowed us the opportunity, demanded of us to look at things differently as providers and as practitioners along the way, to serve the public need and to serve the patient need. And I would suggest to us that we began the very first session began talking about the old days, the days of, excuse me, of working separately, the days of competition versus collaboration. And while all of the things that have been brought up this morning are important and critical and need to be taken care of, one of the most important things we need for our future is to understand how far we have already come on this path. And that we have accomplished a great deal in moving the ball forward on behalf of the people that we serve and the problems that they present with. And that as we move forward in this time, as Dr. Stano said, this very, very critical time that no one knows what the new normal is going to be. No one has a clue how this is going to sort out financially and all that. But one of the things that you and I can control, we have the opportunity to make a decision about today, is how we'll continue to work, cooperate, collaborate together on behalf of those patients, and that will, in times of crisis, and as pressures increase for financial reasons and other reasons, that we don't step back into our siloed perspective. We maintain our coordinated and integrated movement toward greater capacity for the system, regardless of how it's paid for, et cetera. But as a whole, that we model what we want to see among the patients that we serve, and we model the behavior and the concepts that will allow us to bring forward greater good for populations, regardless of the care that we provide and in the setting in which we provide it. So thank you very much.
Thank you so much. And here, so true. The opportunity, every crisis breeds an opportunity, and COVID has brought much more exposure for new populations of patients, but also practitioners to experience team-based care that maybe didn't really have that exposure previously. So there is a new experience happening. A genie is out of the bottle with telemedicine and also with team-based care, because it's all hands on deck that hopefully this field and all of us collectively can carry forward. So I appreciate that very much. Tracy got that hello in beautiful Michigan, right, in the background.
Can you hear me? Can you hear me okay?
We can.
Okay, great. This is actually, shocker, Northwest Arkansas.
Oh.
Which is where I live now. So it's a real pleasure to be a part of this group. And I wanted to just share one of my favorite mantras has always been, and boy, I'm using it a lot now, that we can't have breakthroughs without having breakdowns. And clearly, I mean, here we are, right, in the most massive breakdown, certainly of my lifetime. So, and I also think that creates the time for us now to radically redesign a couple of things. First of all, what healthcare is, so that comprehensive integrated pain management is not simply pasted onto the current system, but is actually in a system ultimately that is finally designed to have that at its core, that kind of an approach at its core. So we have to radically redesign what healthcare is, and then how we actually deliver it, and how we pay for it, which are the themes I've been hearing a lot, certainly today. And in that future state, in my opinion, clinical care, while it's still an important piece of healthcare, is no longer the centerpiece of healthcare. That self-care and the support for self-care becomes the centerpiece of healthcare. And I know you heard a lot of this from Ben yesterday in the whole health work, but I was also today reflecting on, I hadn't really thought about this before today, but you know, as we talk about patient-centered, and then we take it one step further and say it's not patient-centered, it's person-centered, and then we take it one step further and say it's actually, I've always liked person-driven more than person-centered, meaning the person is not just having things done to them and at the center, but they're actually driving it. And today, in listening to the conversation, I thought, you know what it really is purpose-driven healthcare. That we actually, as a healthcare system, that radical transformation is that it's now designed to partner behind people in realizing their purpose and living their fullest life, whatever that is for them. And that's a very different paradigm. So I am really, I really truly believe that all this work that's been happening for decades, that the time really is now, because of this massive breakdown, to truly, I mean, to really radically transform all of these large system aspects that we've talked about. And I'm certainly, in my new role in the Whole Health Institute, we're so committed to being supportive of those kinds of transformations in any way we can be. So count us in.
Thank you so much. And that enthusiasm, aspirational but achievable, is infectious. And AACIPM has certainly brought an incredible group together to sort of feed off each other with this sort of next steps of ignition. Courtney, can you share with us from your perspective, please?
Hi, my name's Courtney. I'm a clinical pharmacy specialist in pain management. Just wanted to bring attention to the fact that advanced practice pharmacists, we are essential members of the patient-centered integrative pain care team. We're the medication experts on the team, but that's not all we do. And certainly we can help with medications, but we also connect patients to non-pharmacological options. And for us, provider status is critical to enable us to be able to bill for our services. And I would just welcome everyone who's here to take a moment to think about maybe what your next step is when you get back to work, of how you can move more or better towards patient-centered integrative care. I know for me and my practice, started building a team of like-minded people who advocate for this type of approach and work towards making even small changes can add up over time to turn into something big. So.
Thank you, Courtney. Pharmacists are a key part of our integrated team, and we're so glad that you're here to share some of those thoughts with us and to help ignite the action among your constituency. Eric Schumacher.
Well, good afternoon.
There you are. Hi.
I'm right here.
Thank you.
Thank you for this opportunity. And I just want to, my background is in the military. I have my COVID haircut, as you can see, but I'm wearing my West Virginia shirt today out of respect for this terrific presentation. And if I had a Vermont shirt, I'd have a Vermont on one side and WVU on the other. I also want to have a shout out to a group that has joined us from Canada, Ramesh Zacharias. This is an international webinar. They are pursuing some of the very same things that the groups represented here have been doing for some time, and I welcome them. You know, this has just been a remarkable day, and I've been energized and really made very optimistic by what I've seen, and I've been mentored by so many of you on this webinar, and so many of you who have spoken. Dr. Klum, I think, Dr. Stanos, and of course Tracy have echoed, and you, Rebecca, my thoughts about this, that I'm reminded of that old trope that the Chinese symbol for crisis is danger and opportunity. It's two words in one. And I think, as Tracy has so eloquently outlined, we have an opportunity here, and you said too, Rebecca. In crafting what I thought about for my final comments, I have to go back to why my colleagues and I in the military and veteran health and healthcare world looked to improve optimal comprehensive pain management about a decade ago, when I was still in uniform and conceivably could do something to try to move this leviathan of military health, which is about the same size as the veterans health space, toward what was needed. And our motive is really from our patients, or what Tracy would say, the people that we're serving. We had returning soldiers and other warriors from 2 wars of unprecedented length and ferocity, and their families, and our retired soldiers and their families from really all eras. And what they told us in virtually every forum we had, and through every means they could muster, was that that our efforts to relieve the suffering that they had from pain, especially chronic pain, were simply not working. In fact, it was harming them in many cases through these invasive procedures, through addictive drugs, and through a large array of unaddressed psychological and social challenges they faced. And through the efforts that we undertook within the Army and later the Department of Defense, with the help of the Veterans Administration and many of you on this video, we came to understand that we needed this patient, I'll say now, person-centered, team-based, comprehensive, fully integrative system of evidence-guided pain management. And we couldn't keep doing what we've been doing for 150 plus years, ever since opioids were introduced in the Crimean War and the American Civil War. We've had presenters over the last 2 days that say that our legacy approach, both our clinical, business, organizational, leadership practices, are badly broken. whether in West Virginia or in Vermont, in the military health system, the Veterans Administration. If given the choice, chronic pain patients will seek a holistic, fully integrated, and tailored approach to their pain, in which they partner with the entire team that's committed to this biopsychosocial scheme of care. And I'm sorry, I should have anticipated Dr. Seidner and looked at even further in a bit more expansive approach that focuses on well-being and their aspirations for optimal function. I fully agree with what Dr. Gaudet has said. Our colleagues from the employer community, our health benefits designers and payers have validated, I think, in the last 2 days and beyond this perspective. And so I return to something we said a decade ago, which is, do we have the courage, the ethical strength, the collective intelligence, and the wisdom to go where our patients are taking us? So thank you again for this opportunity to participate, and I look forward to the outcome of this meeting and further meetings like this. Thank you.
Thank you so much. Matthew, we just have about 1.5 minutes for you to help bring us home.
Okay, so the guy that suggested the 90-second pearl gets to go, right?
You do.
Well, thank you. I'm the representative for the International Association of Yoga Therapists, and I'm really excited to have seen the collaborative experience that we've had here with the Alliance. And echoing Jerry, I think, you know, I like to talk about yoga therapy as the first new health profession of the 21st century. And it's been so invigorating because 40 years ago, there was a lot of division between we pain providers, and now to see the collaborations that are coming forward and it's so beautifully portrayed today. So I've got a couple of little pearls under my short pearl necklace. The first is the support and inspiration of the just published Yoga Therapy and AACIPM white paper by IOIT, and that's yogatherapy.com/pain.pdf. I think it's an inspirational document that we can each discipline should take and model and write it for your discipline. So we're all echoing, the echo chamber of AACIPM begins to move beyond, you know, the last 3 years. The next is shout out to Sherry McAllister and her amazing crew at the Foundation for Chiropractic Progress. We put together a patient flyer on how chiropractics and yoga therapy work well together, and that's at yogatherapy.com/dc.pdf. We should all be creating those between our professions, and please steal from us, use the template and make them to get the words out to keep bringing down these barriers between us. Another one is the literal spirit of cooperation in the Alliance's spiritual pain care work group that I've been on, and where we talk about who, what, when, how, and what's holding us back to literally giving bones to and spiritual care in our AACIPM definition. That how do we bring that forward? It's one of the really big keys out of that definition. And my final pearl, I have a huge opportunity to create and go to scale in the work I've been doing with Dave Elton at United Healthcare Ventures. We're bringing yoga therapy into the orthology team there, as well as their research center and beyond. And his team, Chuck, Rachel, Jonathan, and the rest, they all work across their disciplines to create what hasn't been yet. We know and so it has the spirit of fast innovation. Let's see what sticks. Safety first and foremost, backed by data collection, and it's a true model, I think, that's going to rapidly advance AACIPM sooner than later. And so I hope you can see why I'm excited about all of our collective efforts here at the Alliance. Thanks, Ron.
Thank you so much, Matthew. And I see we're out of time and we have to turn it back to close out. So the pearl I'll share is really gratitude to everyone who devoted time to the symposium over the last 2 days. The team-based care was helpful for all of us in our respective roles as healers, as caregivers, as people who care, and as people with pain or people who care about them. So I'm just so stunned and inspired by the last 2 days, and extreme abundance of gratitude to Amy Goldstein and the team for what is a very exciting first next step toward our collective work together. Robert, is there anything we need to cover before we turn it back to Amy?
No, I think that's it. So thanks to everyone for staying the last 2 days, and we'll turn over to our fearless leader, Amy, for closing us out and talking about where we can go from here.
Thank you all.
I hope Amy comes up while we're putting up the last slide. This is Kevin. We will take it home, and I'll reiterate, thanks to Amy and the team. This was an amazing virtual event that I can't believe it happened. I had started making some comments based on the pearls that we heard, but it would just be redundant at this point. This was like watching the Red Zone channel. There was just too much going on, and you just wanted to watch it all. We have a takeaway slide right now, let everybody know what's expected of them moving out into the future. We want everybody to fill out their post-survey questions, and without having technical difficulties the whole time. My screen just went blank, so I'm trying to pull up that slide, Amy. And I may ask you to step in because it just went dead on me, and make sure I don't miss anything on that list in the limited time we have left. Amy, go ahead.
You bet. Thanks, Kevin, and thanks, everyone. I am just feeling so much gratitude, too. This was wonderful. I am so inspired, and it's just heartwarming to hear how inspired everyone is. I think that if we build it, they will come, and we just need to take our responsibility that each of us can do to move this forward. That's really what I've taken away, is the answer is within each of us, and we just keep this moving. And so Kevin was about to share, just as a reminder, we want to know your pearls. We want to know your feedback. It's really helpful for us. The change of format, doing it this way, has really created just a new opportunity. And I think, again, another theme with COVID, everything is different and we don't know where things will go. So please complete the survey. Tell us all the feedback you'd like to share. Recordings of all of the sessions will be shared. We expect you'll be able to find those at our symposium material link next week-ish. We think that should be right. Tomorrow, you will all be receiving an email with this survey link again. So please complete that. And again, reference all of the materials that you're looking for on our website at Symposium Materials. And we look forward to hearing from you. I just want to once again thank everybody who was involved in this. I realize there are many people involved who may not have been a panelist, and many of these attendees have also been involved, but for all of the panelists, all of the behind the scenes workers, you have all given so generously of yourself towards this effort. And I am humbled to be a part of it, and I thank everyone and look forward to many good things ahead.